I'm going to argue that globally, lockdowns shift the burden of disease from the powerful and the wealthy to the less powerful and the poor. So these are kind of in order of increasing drama, if you like, or provocativeness. The fourth claim I'm going to argue for is that the global preference for lockdowns is due to this fact, to the fact that they favor the interests of the rich and the powerful. The fifth is a sort of optional claim that I'm not particularly wedded to. I'm just going to briefly argue that although, as with almost everything, lockdown becomes politicized so that it's sort of aligned with one or other on a side of a political spectrum, there's actually no reason to think of lockdown as being somehow a left-wing policy or a right-wing policy. I'm going to give you an argument to think that it's as much of a right-wing policy as a left-wing policy. And I generally think politicizing issues is completely unhelpful to understanding them. And anyway, you don't have to accept that part, that final claim, to accept the first four. I am not going to argue that all lockdowns are always wrong or anything like that. That would be silly. Sometimes, clearly, they are. I mean, lockdowns in the face of Ebola, you know, are a different matter. It's a different disease, and so forth. And you know, I'm not saying all lockdowns are always wrong. I'm talking about some lockdowns in some situations. I'm not going to argue. I'm not going to deny that COVID-19 is dangerous. I'm not going to say that people should do nothing. This is also something that comes out a lot. It's like, well, you know, it's a choice between lockdown and nothing. That's one of the things I think one should resist. There's a number of different measures one can take, and I'm not suggesting that the right thing to do is just do nothing. As I said, I mean, actually, the logical thing to do, if you're saying that the lockdowns are being overused, is to say that other measures should be more used, not that you should not lock down and not wear masks and not wash your hands and generally not restrict numbers of gatherings and so forth. I'm not going to argue that it's conspiracy or a fiction, and it's one of the weird things about this is that these things bleed because of the way the political landscape is at the moment. As soon as you start saying something like, look, I'm not sure that it's actually such a great idea to lock countries down, people immediately think that you're kind of, you know, on the internet at 3 o'clock in the morning, you know, tracking down conspiracy theories. And that's not what I'm doing. It's not I'm not, you know, arguing that any political party or figure or cause has got it right or wrong completely. I don't think many people have, unsurprisingly. There are also a lot of things that you can talk about, philosophical topics about as well about COVID-19. I'm not going to discuss here. So I'm not generally going to go into much about facts and figures. It's frustrating the extent to which the discussions about this pandemic concern facts and figures, when actually, you know, if you give somebody a number, what does that mean? You know, 43,000 people died of COVID-19. Is that a big number or a small number? You know, without some kind of comparator, we have no way of telling. So I'm not going to do that. I'm not going to talk about the role of modeling, which is very interesting from a philosophy of science perspective, nor about causal inference, nor really about the interplay between science and policy, between culture, politics, and the response. I'm not going to talk about financial interests. All those are very fascinating things. There's just so much, I think, people are going to be talking about for years about this, and even though we're already sick of it, there are actually a lot of things that are that are fascinating from a philosophical perspective that I'm not going to engage here. Briefly, you know all this really, but the history of this pandemic. First case occurred on the 31st of December. Well, the first case was recorded on the 31st of December in 2019, Wuhan, in China. And the reason really that things took off in the way that they did is that hospitals in that city were overwhelmed, you know, that month or within a month. I mean, by the end of January, in a few weeks. And that city then responded with a dramatic lockdown, really serious. You know, people had to stay home, order food, and so forth. And nonetheless, the disease reached the rest of the world. In March, scientists produced, although they didn't publish, but they produced predictions of extremely serious global consequences. And the response was, for the most of the world, was to lock down. Much of Europe and Africa and other parts of the world did. Not everywhere. South Korea never locked down. They've used contact tracing. Sweden never locked down. They used classic infectious disease control measures, social distancing. America and Brazil have sort of had no national response, no clear national response, and most countries have had a national response. And many of those countries have been locking down, but not everyone has. But lockdown has been this sort of the not quite, kind of the gold standard. It was certainly what the World Health Organization was recommending. COVID-19 is, as you, I suppose, know, caused by this coronavirus, which is a kind of a virus, SARS-CoV-2, and it transmits through droplets on surfaces and in the air. Symptoms develop in less than a week, and you can die from it, or you can have almost nothing from it. It's more dangerous for people with diabetes, obesity, hypertension, heart disease, and certain other chronic conditions. And old people are considerably more at risk. And this is a difference from flu. Old people are at risk with flu as well, but flu is driven by children. Anybody who's got kids will know when the flu season is on at the schools, you just get sick the whole time from kids bringing stuff back from school. COVID-19 is not like that. It's not particularly dangerous for children. It doesn't appear that schools spread it, and so forth. It's very, very strongly tilted towards older people, and that's, I think, a very interesting characteristic of the disease that has a lot of what I say subsequently depends on that feature. So the failure of common lockdown arguments. I'm not saying all lockdown arguments, but common ones. So there was a report produced, as I said, in March of 2020 by a team at Imperial College London, arguing for, arguing in effect for an immediate hard global lockdown. It's interesting that a group of scientists should, first of all, produce a report that's not published through peer review processes, and secondly, should have such a clear policy steer in that report. But I'm not going to talk about that here. But they do make a case. It's not a sort of neutral presentation of facts. It's very clear they are making a case, even though it's not quite explicit. They said that poor countries, they said a number of things. So they modeled 4 scenarios. The first is a scenario of an unmitigated epidemic. And in that scenario, they thought there would be 7 billion infections and 40 million deaths. In the scenario, the next scenario of the model was a mitigation scenario. And a mitigation scenario is where you do some things like social distancing, you keep people apart, but it's short of a sort of a full lockdown. And they thought there would be a reduction, 16 million fewer deaths, so maybe 34 million deaths globally. The third scenario was that, plus something like this focused protection idea that the Great Barrington Declaration was talking about. So the reduction of social contact for the elderly, basically. They thought that would bring the number down to 20 million deaths. But they also said it would have a lower proportional impact in low income settings for various reasons. They then finally modeled suppression. So suppression is where you try to actually prevent the disease from spreading at all. Mitigation is where you allow it to spread, but slower. Suppression is where you actually just try and stamp it out. They modeled that as a 75% reduction of social contacts. And then they said, well, they didn't say this is how many deaths it would lead to. They said, if you start your suppression strategy at the level of 1.6 deaths per 100,000 per week, it'll lead to 10.4 million deaths. This is globally. If the world starts at this strategy at 0.2 deaths per week, that comes down to 1.9 million. In other words, they're saying 2 things. Firstly, suppression is by far more effective than mitigation. Secondly, do it as soon as possible, like now, like right now. And that is basically what happened. This is exactly what happened. There wasn't any modeling there of the indirect health impact or of the economic consequences. So indirect health impact means the impact of locking down on health through other means, other than COVID-19 mortality. They made it very clear that as part of this, the poor countries, so that they actually produced 2 reports. One was 10 days earlier, that just focused on North America and the UK. This one focused on the whole world. And they were very clear that the poor countries, although they were in general younger, they stood to benefit a lot less from mitigation strategies because of the shortage of hospital beds in those countries, and because of which would therefore be outstripped very quickly, and because they were worried about higher mortality due to existing diseases. So, I mean, most of the predictions in this report turned out to be false, quite dramatically wrong, and not just that the numbers were inflated, but that they got things all the wrong way around. So, in fact, lower income countries were very much less affected. You know, North America was supposed to be one of the least affected globally in all their scenarios, and in fact, it's been one of the most affected, and so forth. So there's it's a very inaccurate report. That's not what I'm going to focus on here. I'm going to focus on what the argument is supposed to be in that, or around that report. I mean, it's not deliberately presenting an argument. What kind of argument that's supposed to be suggesting? And I think there are at least 4 things that come up in there and in the general discussions that are that I see very commonly. The first one is a kind of precautionary argument. Take care. We don't know what we're dealing with. Better safe than sorry. Certainly early on, that was quite common. There's a sort of idea that we should beat COVID-19 and we should stop. We should fight COVID-19, stop it. Beat it. Which is kind of like the idea you should just kind of stop it from happening, stamp it out. There's an idea that you should sort of wait and weather the storm until there's a vaccine or a cure or a decline in infections or something like that. There's an idea that you should protect the health system. None of these amounts, in my view, to an argument on its own. What you need really, I think, is an ethical framework to put these things in. I mean, on their own, none of those, I think it's fairly transparent, is going to be sufficient to motivate an extremely dramatic intervention by a government or indeed by individuals on their own lives. There needs to be some kind of framework in which those sort of assertions are placed. And nearly all the discussion of non-pharmaceutical interventions has focused on numbers. It just, as I said, it's like, here's a big number. Wow, that's scary. There's a kind of conceptual vacuum. But we've got a lot of bioethical work, which is supposed to help with difficult decisions about health matters. You're not going to get the answer about this from a book, but you can certainly get a much clearer understanding of the decision that we face. And I'm going to try and do that here. This is not an unprecedented situation. So it's quite interesting that people keep saying this is unprecedented, it was unpredictable. Well, it wasn't unpredictable. Lots of people predicted there was going to be a pandemic. Bill Gates did, the World Health Organization did. The fact the world didn't do a great deal to prepare itself is the interesting fact. But it's not at all a surprise that there's been a substantial outbreak of a virus. And it's definitely not the first one that's come along. What is, I think, unusual is the way the world has reacted. So let's consider precaution first. Some justifications for locking down are precautionary, and there's the way that bioethicists talk about this is in terms of the precautionary principle, which is supposed to warrant taking an action when there's a really big danger that you're trying to avoid, but you don't, for whatever reason, you can't do, or you don't think you have to do a full, proper sort of cost-benefit analysis. And there are 3 ingredients most people think to a precautionary principle. You have to have a damage condition satisfied. So it has to be the case that something really bad might happen. There has to be a knowledge condition, which is either that it's uncertain that it's going to happen, or that the probability of it happening, although low, is still high enough to merit you taking the precautionary step. And there has to be a remedy available, which is what you're recommending be taken as a precaution. And when those 3 things are satisfied, what the precautionary principle basically says is that we should act now and fast, and that the normal ways of assessing the cost and the benefits should be set aside. We shouldn't do the normal level of weighing up because the outcome is so bad that it outweighs, and the remedy available mitigates that to such a clear extent that that outweighs, well, it outweighs the whole process of weighing things up. In the background there is supposed to be a picture of found of how to jump out of a 2nd-story window. And here is an example from quite recently. SAGE is the scientific advisory body in the government, saying the evidence base into, that's what they say, into the effectiveness and harms of these interventions is generally weak. However, the urgency of the situation is such that we cannot wait for better quality evidence before making decisions. This was very recently. They were in the UK. The scientific advisory body was trying to persuade the government to take steps to lock down, and they addressed the question of whether there is an evidence base for the effectiveness of lockdown, and they say no, there isn't. And then they give this precautionary argument. So the precautionary principle, I think it's fairly clear, is not generally satisfied in most of the times it's used to justify a lockdown. At present, the time for precaution has passed. I mean, this is November. You know, we're coming up to the 1-year anniversary in a few weeks of the first case of COVID-19, the recorded case. It's inappropriate. It's clearly, in my view, inappropriate for that to be wheeled out at this stage. There has been time to get evidence. There are reviews of effectiveness of lockdown and of non-pharmaceutical interventions of all kinds. I mean, it shouldn't be wheeled out now. I think what's more interesting is that, in my view, it wasn't actually satisfied even back then in March, when it was very, very common, and perhaps you might think it was satisfied. And in case you're wondering, I did say this in March. I started writing about this in March, and I've been saying the same thing. And the reason is that the remedy condition is not met. So you remember there are 3 conditions. The third being that there is a remedy available, which is your precaution, which is what you're going to take. And that is because reducing social contact by 75% can't be done in many circumstances because of overcrowding. So I'm taking a global perspective here, and I think that's very important, because it's often said that this is a global threat. It's a threat to humanity, whatever it might be. We're all in this together. Globally speaking, reduction of social contact by 75% simply can't be done for people who are sharing a single room with 9 other people, maybe share ablutions outside the dwelling place, some 200 meters away. It's not actually possible to achieve that reduction of social contact. That's the first thing. The second thing is that the indirect health effect of doing so is substantial in poor settings. So if people are relying on money they make that day or that week in order to eat or to feed their family, then you're going to see malnutrition. If there are ongoing treatment programs for things like tuberculosis and HIV, then you're going to see a health impact through those things. We know already from what happened in Sierra Leone during Ebola outbreaks, that you see outbreaks of other diseases during lockdowns. You see outbreaks of malaria and so forth, because of people's living standards degrade. The third thing is that lockdown can actually increase transmission in overcrowded conditions. This has been observed in a couple of cases. I mean, there's a famous study in the cruise ship off the coast of Japan very early on, but it's also the case in in Accra, 53% of the population shares a room with lives. 53% of families rather live in a single room. I mean, and if you can see how if you force people to stay indoors in that situation, you're actually going to increase social contact. You're not going to reduce it, and you're actually going to speed the spread of the disease. So it's not the case that lockdown was at that time a precautionary remedy with the scope that it was being recommended. So I'm not saying it was a precaution in no place. I mean, in Geneva, locking down is one thing. Locking down in Johannesburg is a different thing. It very much depends which part of Johannesburg you live in. The next way you might try and cast these arguments is a cost-benefit analysis. So the common arguments for lockdown that I mentioned generally just don't do this. They don't estimate costs or benefits. They don't weigh up costs and benefits. That's not generally how people motivate lockdowns. And I think it's quite difficult to do that. I'm not saying it can't be done at all. Sometimes it can be done, I'm sure, and perhaps sometimes it's the right thing, but you just don't see it. The modeling and I think that's remarkable. The modeling is all focused on near-term COVID-19 deaths. There aren't considerations of the wider health impact, the longer-term health impact. There aren't considerations of other policy priorities besides health, and there are other policy priorities besides health. You don't, it doesn't make you sort of an ogre if you say that there are other things that are important, including education, livelihoods, employment, the effect it has on women to be locked up, and there's increases in domestic violence and so forth. And it's remarkable that there's still, even now, in developed countries, I haven't seen a decent case being made on the basis that benefits outweigh the costs. I'd be interested to see if there is one, but I suppose maybe in the Scandinavian countries they might have done that, but I haven't checked. But it is quite remarkable that is not, most of the way through this year now the common mode in which people are talking about this. We're still talking about cases and saving lives. We're not talking about, does the cost outweigh the benefit? At least that's not the only way these things are talked about, and that's quite remarkable. And then another way you can approach this kind of problem is with a sort of deontological perspective, a kind of categorical imperative. So a categorical imperative is one that doesn't depend on anything else. It might be wrong to steal, full stop. That's an example of a categorical imperative. And that is the rhetorical effect of the phrase saving lives. You just should save lives. You can't weigh that against the economy. That makes you callous. And the trouble is that that's not enough to motivate a lockdown, because two reasons. Firstly, there are many other categorical imperatives that locking down itself violates, in many people's eyes at least: the right to feed oneself, various rights to freedom, and so forth. And one ends up having to set different categorical imperatives against each other. The second is that lockdown itself costs lives. So even if you just consider that one imperative to save lives, well, lockdown costs lives too. So you end up having to perform some kind of utility calculation. So you can't avoid doing utility calculation by appealing to a categorical imperative in this instance. And I think that's commonly true for policy. It's why most policies are not actually motivated in terms of a categorical imperative, even if they're sold that way in the public domain. So most of the sort of familiar arguments to motivate lockdowns aren't that good. I'm going to go further and argue that most actual lockdowns, or not, I don't want to say most, I want to say many actual lockdowns have been wrong. So unjustified, that's one thing. I think I've explained why I think many of them are unjustified. They're given insufficient coverage by any precautionary principle. There's no real balancing of costs and benefits. They don't have a basis in any obvious categorical imperative. That's just a failure of people to justify them. But I think there's actually, furthermore, they are actually wrong. And that's because I think the costs tend to be high, the benefits are often low, and their effectiveness is poor. I want to make it clear I'm taking a deliberately broad global perspective here. And that's because when I see discussions of these things, they often are couched from a perspective that is, broadly speaking, the global north, that it's different from America and Europe, but it's a perspective that's the global north. And then there's a sort of mention of other countries where things are a bit different. And yes, obviously it's different. It's obviously very different in Africa and so forth. I'm going to take a global perspective deliberately because of the fact that most people in the world don't live in Europe and America. And I think that on average, lockdowns are probably wrong. I don't have the numbers to back that up, but given the distribution of wealth in the world, I think that that's probably true. I'd rather start from that presumption and be pushed back from it. I'm going to take South Africa as an example. South Africa is not a poor country. It's a lower middle income country, but it's an extremely unequal country. It's probably the most unequal in the world by some measures. So it has some very poor people in it. The median age is 26. The life expectancy is 60 for men, 66 for women. About bit over half of the country lives below the upper bound of poverty line. 47% of households have access to piped water in 2018. Leading causes of death are TB among men, diabetes among women. So in this country, I've looked at it a lot because that's where I'm based. That's where I work, and South Africa locked down very, very fast, as did most of Africa. They were commended for doing so. It was one of the most stringent lockdowns globally, and there was a memorable period of time early on where deaths due to police brutality outnumbered deaths due to COVID-19, due to the enthusiastic enforcement of the lockdown by the security forces. So, it's an interesting case. So what are the costs and benefits of lockdown in South Africa, and in for some of the people who live there? And by benefits, I mean the protection that's offered against COVID-19. Well, one of the things that we got a small grant to look at this, and one of the things we've done is we looked at the lockdowns over time compared to the caseload. South Africa had random testing, quite an extensive program of testing, which is quite good. And what South Africa did is it locked down in levels. So the highest level of lockdown was level 5, and that's indicated here by that arrow that says 5. The country entered lockdown. The first case was on the 5th of March. Mitigation measures were taken around the 15th of March, and then the country entered lockdown on the 27th of March. You can see that on the day it entered lockdown, there was a sharp decline in the total cumulative total of cases. That obviously cannot be due to going into lockdown, because the effect isn't immediate. It would take a week or two. After that, it's pretty straight, that green line at the top, until it all starts to level out. At the bottom, what you can see is the daily caseload, new cases per day, and that goes up in an exponential curve. The green line is on a logarithmic scale, so it's a straight line. That's the right way to look at an epidemic. A straight line on a logarithmic scale means that it's spreading at the same rate, even though that looks like it's going up at a curve on a linear scale. If you look at it on a logarithmic scale, you can see what you see is a more accurate reflection of the rate of the spread. And it's a straight line, and then it tails off. And it doesn't seem to matter what happens to the lockdown levels. So lockdown was then lifted to a slightly lower level 4 at the start of May, and then lifted again to 3 at the start of June. And the cases were all still very low. During level 3, it went rocketing up, but if you look at the green, as I say, at the green line at the top, on the logarithmic scale, it's a straight line. This is a constant rate of spread. If you think about it in terms of an area, the area the disease is covering is growing at a constant rate, if you want to think of it visually. It then peaks and it tails off again, and it continues to tail off. The country unlocks down into level 2, and it continues to tail off. So this is what actually happened. It doesn't look like there was an effect of changing regulatory measures beyond perhaps initially introducing the mitigation measures, restrictions on large gatherings and so forth. So the additional strict, through all of this, you've got restrictions on large gatherings, and those kinds of things, requirements to wear masks and so forth. Those things, I'm sure have some kind of an impact, but you don't see, obvious effects of these higher level of restrictions in this context. We also we compared some townships and some suburbs. So townships means slums in effect, and in a comparable area. And it's interesting what you can see you can see on the right of each of these here, after you go down to level 1, you can see a resurgence in the suburbs, but not in the townships. And this fits with the idea that basically overcrowding is what explains this. So and on the ground, it's quite implausible to imagine that people will be able to stay in a one-room shack with 9 other people, and that's going to work. So the hypothesis, I mean, my hypothesis is that the reason you see this is not that in principle lockdown doesn't work. It's just that if you apply it in this context, it doesn't, people either can't abide by the regulations, or they won't, or even if they do, they're still in very close contact with each other. I mean, something like 1/3 of the country depends on social grants that has to go out, and people have to go out and stand in queues to get those grants. They have to queue for food parcels when which were being distributed for people who are hungry. There wasn't an effective reduction of social contact, which would explain why these changes in the level of lockdown didn't make any apparent difference to what happened. On the cost side, so the benefit doesn't look to be particularly large or even apparent at all. I mean, you can't see, with the benefit of hindsight, you certainly can't see a benefit of locking down. In terms of excess deaths, whether or not these are a cost of lockdown is hard to say, but it's clear there have been a very large number of excess deaths in South Africa, as in many other places. So at the bottom, you can see COVID-19 deaths in that graph, and at the top, you can see excess deaths, the total number of deaths compared to last year, to what we would expect at this time of the year. So it's a very, this is larger, depending on how you calculate expected deaths, anything between 13 to 29,000 unaccounted for deaths. And it's very unlikely these are all due to unreported cases of COVID-19. South Africa has a very active civil society. People would be on the government's case if they were not reporting, 30,000 cases of COVID-19 death. That said, the South African Medical Research Council says they do think these are COVID-19 deaths. I don't agree. No, I don't think that can be correct. It's not plausible. So there are a large number of excess deaths. Attributing them as a cost of lockdown, however, I don't think is fair or reasonable without knowing what would have happened otherwise. So it could have been even worse had there been no lockdown. So although there are many excess deaths, until we know more about the causes of death, and that data is not available in South Africa, it is in other countries, but not in South Africa, then it's very hard to understand whether they are a cost or a benefit. However, indirect health effects that are clearly costs, and these are mostly, however, lying in the future. There has been disruption to treatment programs that we found that leads to a probable rise in HIV, TB incidents, an elevated risk of outbreak of diseases due to the vaccination, disruption of vaccination programs, probable risk in incidents of probable future rise in instances of malnutrition. I mean, schools were suspended for one thing, which is a big deal because many children rely on a school feeding program, which gives children at least one square meal a day. In South Africa, most children do go to school. Outcomes are very poor, but most children do have access to school. And at school, many children rely on a meal, as I say. There is presumably a future rise in incidence of substance abuse and a probable future rise in the instance of mental health. These are all unsubstantiated. We haven't been able to measure them. We have been able to observe the disruption of the treatment programs, as I say, but they are quite likely to occur. And in a sense, this is public health 101. So we know from many other instances that the same intervention can have different effects. The picture on the right is a market in Bangladesh. There was an infant nutrition, this is a famous example, infant nutrition program in Tamil Nadu that was effective. They educated the mothers. The mothers then fed their children better. They tried to implement it in Bangladesh. It didn't work, and then they figured out this was because in Bangladesh, firstly, the men do the shopping. It's a marketplace in Bangladesh. Everyone there is male. It's a Muslim region. The men are doing the shopping, and then secondly, it's not the mothers of the children, but their mother-in-law that controls distribution of food within the household. So educating mothers works great in Tamil Nadu and didn't work in Bangladesh. We know this from many other examples as well, that the same public health measure doesn't work necessarily in different contexts. And that's how it seems to be here. Locking down doesn't reduce social contact by 75% in all places. Staying home isn't the same thing in a suburb with a laptop and wearing pajamas and drinking coffee as it is in a slum without a job, in a room with a lot of other people, some of whom may be abusive and so forth. And regulations achieve different levels of compliance in different contexts. When it comes to public health, one size definitely doesn't fit all. So globally, this is perhaps, each step is perhaps more controversial than the last, which is what philosophy, I suppose, is about. Globally, lockdowns shift the burden from the rich to the poor. So I just want to compare a rich country and a poor country, a very rich country and a very poor country. So Malawi is a very poor country. UK is a very rich country. Malawi, the median age is 72. The median age in Africa as a whole is 19. The median age in Europe as a whole is about 40. So UK is about typical. Malawi is a little on the younger side in Africa, but not by any means the youngest. The youngest countries in Africa have a median age of 14, which is kind of incredible if you think about it. Half the population is 14 or under. In Malawi, it's 17. That means a lot of people are dying when they're children. That means the UK is 2.4 times older than Malawi on average. The GDP is about 7 billion in Malawi, $389 per capita. In the UK, it's 2.8 trillion or $43,000 per capita. So the UK is 404 times richer in a country, or as a country, or 108 times richer per capita. Deaths per million. Well, I mean, you can read it. The Malawi, I just updated this evening. Malawi, since I last looked at these numbers a month ago, Malawi had 181 deaths. Now it's got 185. The UK had gone up from somewhere in the 40,000s to it's crossed now 50,000. We're going through a surge in the UK. It's 275 times harder hit in terms of deaths, or if you do it per million, then it's 75 times harder hit, considerably harder, about as many times, not quite as much. It's still, you know, it's over 100 times richer. It's less than 100 times harder hit, but it's still, you know, considerably harder hit. I'm just the reason I'm doing this is just that I think that the scale matters. You know, it's not just like it's a bit richer. It's a lot richer. And it is being a lot harder hit by COVID. Age and wealth are very strongly correlated. I got these both from Our World in Data and the World Bank. You can see on the left is wealth per capita, and you can see where the poor regions are and where the rich regions are. And if you can sort of mentally transfer that, I tried to see if there was a way to do this visually or not, but I decided just to ask you to look at it. You look over to the right, you look at it's pretty much the same, more or less, pattern, except that the younger places are the poorer places. And that kind of stands to reason, because if generally speaking, if a region is wealthier, it's going to try and you know, look after itself and live longer. That's one of the main reasons people want to be wealthy. COVID-19 death rate is also correlated with age. So this is actually quite old data, but it gives the right kind of picture, which is older groups are considerably more likely to die from COVID-19, very considerably. Once you get above the age of 60 or so, it's considerably higher. So you have this situation: age and wealth are correlated. Age and risk of serious or lethal COVID-19 are correlated. The impact of lockdown on COVID-19 transmission is correlated with wealth. And that's because poor people more likely to be living in overcrowded conditions, may need to leave the house to get food and so forth. The indirect health impact of lockdown is inversely correlated with wealth. So it's because malnutrition and disruption to health programs and so forth affect poor people more. And lockdown therefore results in reduced health burden on the rich and increased health burden on the poor. It does depend on the comparator. The implicit comparator here, as I'd say, is not doing nothing. It's some level of mitigation measure that is short of a full lockdown, like some kind of social distancing measures. It's not doing nothing. I just want to re-emphasize that. So let me not go through this, but I just look at the time. Yeah, I won't go through this, but what I try to do on this slide is just say, look, if we look at it globally or locally, you get the same effect. If you lock down globally, the effect on the poor country is more life years lost among the global poor. If you lock down in the rich country only, but not the poor country, that's the best case scenario of all of those, but it's still going to be bad for the poor country because the global economic downturn is going to be bad for the poor country, and people are going to lose their lives. And obviously if you lock down in the poor country only, that's kind of the worst of all worlds, because it's going to be least effective, and it's going to be pretty bad everywhere. Global use of lockdowns is due to their favoring the interests of the rich and powerful. My argument here is really a kind of an inference to the best explanation. I mean, there's loads of stats. I'm not really very good with stats. I'm an ideas guy. I'm a philosopher. But 800,000 children died of pneumonia in 2017. That's pretty normal annually. 5 million die each year of preventable causes: sepsis, pneumonia, and malaria, and all that sort of thing. These are big numbers. We've got now over 1 million people died of COVID, but every year 5 million children under 5 are dying of normal diseases. But that doesn't trigger this kind of effort. It just doesn't. The only reason I can think of is that they're mostly poor, powerless people. These are not, like, most of these people are not like my children. They're the children of people who don't have very much money or power. That most of those child deaths are not occurring in, in the UK or in wealthy populations in poor countries either. I just can't think of a better explanation than that this is a disease that threatens people with power. It threatens it threatens world leaders, including world leaders in poorer countries. I mean, the average African leader is in their 60s, even though the average African is not. And the tendency to travel overseas and get healthcare was suddenly closed down as well during lockdowns. So I think that may also explain why, even in countries where it clearly didn't serve the population as a whole, leaders were strongly motivated to enter a lockdown. I know that COVID-19 hits the poor and the disadvantaged harder in wealthy countries. It takes a disproportionate toll among ethnic minorities and disadvantaged groups, very, very much so. That is because in developed countries, there's no mystery about this. It's because in developed countries, poverty correlates with the risk factors for COVID-19, obesity, heart disease, and effectively shifts that age curve down. Life expectancy comes down with those chronic diseases. But in poor countries, poverty does not correlate with those factors, or at least not as much. It's complicated. But the majority of poor people who suffer health effects from poverty are suffering from things like malnutrition. And most poor people live in poor countries. Most poor people do not live in rich countries. So while it is the case that COVID-19 is within the context of, say, America, does take a disproportionate toll among people who are disadvantaged. Interestingly, and I think there are many interesting, contingencies about this disease, but interestingly, that doesn't extend to the poor when one takes a global perspective. And I think it's a striking feature of the tilting of this discourse to the global north, that it's become accepted that people just say, well, obviously COVID-19 is particularly bad for disadvantaged groups. Well, it's actually not. If by disadvantaged groups you really mean disadvantaged groups unqualified in the world as a whole, it's particularly bad for advantaged groups. If you mean that, if you mean disadvantaged groups relatively within a relatively wealthy country, then yes. But if you don't qualify it in that way, then it's false. Finally, optionally, lockdowns are as much right as left politically. I think that it's ridiculous that it's become, the discussions about lockdowns have been politicized in the way that they have. The view seems to be that lockdown means restriction of liberties, and that means it's a sort of left-wing measure. And people seem to think that's why it's become associated with the political left. I don't think that can be why, because you could equally see it as a right-wing measure, because you could see it as people just protecting themselves, nations deciding to protect themselves. If that were the stance, then the right could just as easily have adopted lockdown. It's also interesting that in Sweden, the party that is in power is on the left, and it's the right that is calling for a lockdown. So I just think we shouldn't be fooled by the politicization of everything. These things are quite it's quite contingent which side of the spectrum takes up this particular cause. I'm not going to speculate as to why one rather than the other, but I certainly don't think one can meaningfully say that lockdown is a kind of, if you're on the left or on the right, you should or shouldn't be in favor of it. I want to just say that. So this is what I've attempted to argue, that to summarize, several common arguments for lockdowns fail. Many actual lockdowns have been unjustified and wrong. Globally, lockdowns shift the burden of disease from the powerful to the less powerful. The global preference for lockdowns is due to their favoring the interests of the rich and powerful. And as an optional extra, this doesn't have much to do with the political spectrum. Yeah, I think let me leave it there. Thank you very much.